So good afternoon and a warm welcome to all. It is a pleasure to be a part of this IC in this pandemic and in the virtual meet. So my topic for the day is trifocal challenge. Is chord length mu an important factor in presbyopic IOL surgery? See, presbyopic correcting IOLs, there are a lot of IOLs available at present, and the latest generation trifocals and the hybrid lenses are the one which has hit the market for quite some time. A lot has been talked about how accurate we can be with these presbyopic IOL, with the way we have to calculate the biometry, how to do a surgical technique to get a successful surgery. But still, a lot of surgeons all over India are a little bit skeptical about adopting a presbyopic IOL for the patients for a simple fact that they are scared about the postoperative refractive outcome, or they're also worried about the dysphotopsias the patient could complain of after the surgery. We have seen a lot of patients, 6/6 and N6, still this pupillary axis and visual axis do not coincide, and there's always a difference. A difference is more when the patient has a phoria or a tropia where it is enlarged. So whenever we look into the biometry, we usually look into the axial length, make sure that all the spikes are quite good, and then we look into the astigmatism. Most of the surgeons stop at this level, and it is most enough for a normal IOL. But when you're going into a presbyopic IOLs, you also have to go down and look into the chord length mu, which is denoted in all the optical biometer nowadays. So the chord length mu is a measure of the deviation from the pupillary axis in the X and the Y axis. Both have to be added together to give you the difference in chord length mu. And the chord length mu actually varies in different pupil sizes, mesopic, scotopic, and photopic vision. It is always a good practice to measure the deviation of the chord length mu in all these different lighting conditions. And when you have a deviation of more than 1 millimeter, you have to be really careful, because these are the patients, when you give them a 6/6 vision, they still complain of dysphotopsia because of the variation in the center of the pupil and the visual axis. And see, as I told you, in a perfectly centered capsular rhexis, the IOL normally centers itself in the back. So most of this has to be decided preoperatively whether this patient has to get an IOL, this presbyopic correcting IOL or not. But however, when you have a compromise in the capsular rhexis margin, the IOL can change its position. The only lens where you need not look into the IOL centration are the PMMA lenses or the spherical lenses. But nowadays, the spherical lenses are not used much. So most of the lenses are aspherical lenses, and for all aspherical lenses, you need an IOL centration, including more so when you're using a toric lenses or the multifocal lenses. As I told you earlier, though the IOL is going to center itself in the center of the back, it is always a good practice to make sure that the IOL is centered with the optical axis. This we do by coinciding the Purkinje images 1 and 4. So define what a Purkinje images are and how useful it is in surgery. The 1, 2, and 3 Purkinje images are real and errate because they are reflected from a convex surface. The Purkinje image 4 is from a concave surface, hence it is the only image which is real and inverted. So this is how the Purkinje images looks like when we do the 3. So as we could see here, this is a trifocal one. The Purkinje image 2 actually is not visible because it forms the center of the anterior chamber. So all we have to do is to align the Purkinje image 1 and 4 as shown here. Different microscopes have different to define these Purkinje images. Here, this is from a Vishu 160 microscope, which shows you 2 dots, one larger and bigger, which are used to coincide both the optical and the visual axis and at the end of the surgery to ensure that the IOL is placed in the center. So this is an image of the postoperative where you could find these trifocal IOLs well centered and the optic and visual axis almost coinciding. So to come back about the importance of chord length mu, this is a very important study which showed that they took people into 3 groups. The first group had a chord length mu of less than 0.2, the second somewhere between 0.2 and 0.4, and the third was between 0.4 and 0.6. The most important thing, note that all these patients in this group were emmetropic or they had very good vision or spectacle independence. But when you ask these patients about the dysphotopsia through a questionnaire, it was found that the patients in group C, that is the patients who had a large amount of chord length mu, did complain of disturbing glare and halos. So the take-home point is that your chord length mu is not going to disturb your prediction error, but it is going to play an important role in giving satisfaction to the patient and reducing the dysphotopsias. So you can go ahead safely and implant these presbyopic lenses when you have a chord length mu of less than 0.4. If they are more than 0.4, be prepared to deal with the dysphotopsias which the patient is going to complain of. Thank you.